Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to once again partner with Drs. Margot Adams-Larson and Sarah Smucker-Barnwell to present these telehealth community chats. In the interest of time, we've placed their bios on a slide for you. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other Trust CE credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Thank you so much, Dr. Martin, and thank you to the Trust for having us here today. Thank you everyone who's joining us. We're delighted to see you. And Margot, it's good to see you again.
You as well. I'm excited to get chatting.
Likewise. Well, we have a lot of great topics to talk about. Thank you to everyone who wrote us in with topics and questions. We've done our best to incorporate those into the themes we'll speak about today. As always, we'd like to start off with a few disclosures. You know, Margot and I both participate in work that involves telehealth training, so we always like to disclose that we have a vested interest in telehealth working well. It is not surprising because we are known telehealth enthusiasts, so these things aren't unrelated. These are themes we're very passionate about, and we hope we can communicate that to folks who join us for these talks. We also like to disclose that inevitably, when you talk about technology, something goes wrong with your technology with an almost sentient like vengeance. So we've put it in our disclosure slide that inevitably something may go wrong with our technology. If that does occur, please bear with us, stay on the line, and we will do our best to remedy it in real time.
Well, I want to welcome everyone as well. And Sarah, this is probably my favorite part of the week, getting to chit chat and catch up on what's been going on. As we have been doing this every other week, we're transitioning now to a monthly chat. And so there's a lot coming in between. And just to give everyone a heads up that will be another month before our next one, and lots of opportunities to email in to us at the telehealth community at trustinsurance.com, and your question will get to us. We've had several come in right before this, so we'll hope to include those in our chat today. Kind of a reminder that really we're here as a discussion, a conversation, some of the practical how-tos for information, remembering our ethical considerations, thinking about the regulatory environment, factoring in clinical concerns, and in general, the everyday down to earth, what are we going to do in telepsychology? Certainly, you may have a lot of questions that might rise to a risk manager level, and we would encourage folks always to reach out to our colleagues on the risk management team who can help with very specific individualized questions you may have. But we are loving the ideas and concepts and questions that you're sending in, so keep them coming. Our goal is really to provide some answers and or some steps for you to get your own answers that might be relevant to a very particular individual question that you have. Over the last many chats we've kind of gathered our list of resources and guidelines. These will be in the set of slides that'll appear in the resources after today, so that you have a way of accessing the information that we might refer to and definitions that we may chat about. So without further ado, couple key points of just overview of the agenda. What we've found is it's easier to take the slides down and you can see us a bit better without having to look around the PowerPoint. So we'll take the agenda slide away, but at the end we'll bring that back and we'll bring back the resource slide and some more information. So the submitted questions that we have this week fell in a number of different areas. We'll be covering providing care to younger or elder clients via telecommunication approaches. We'll discuss communicating with the insurance companies. We'll discuss, again, interjurisdictional concerns. I think this is always probably going to end up on the list, Sarah, because there's endless questions. And then also with fall approaching and universities back in action, we have some really awesome questions about new students coming into graduate programs who have never done any kind of therapy before, and ideas and things to consider with regard to teaching all of this in perhaps a remote approach. We'll have live questions spaced in between as well. So I am going to stop sharing the screen so that we can continue on our conversation. Hopefully, can you see me all right now, Sarah?
I can see you great.
Awesome. Well, one of the things that we've had a lot of questions about over the last probably several months is topics of teletherapy with younger children. And lots of colleagues that have found some really neat hacks and pivots and strategies that I thought maybe it's a great time to just bring up a few of those, think through and discuss through again some of the unique challenges that working with children always brings, whether you're in the office or remotely working with them. And you know, one of the first things that comes to mind really is often kids are very drawn to technology. It's a conversation that we have from parenting side, from the pediatric side, how much like they're on Zoom all the time now for school. Like, do we really have to do Zoom for therapy? Kids should love it. They've always loved it. And now it seems like kids are getting bored of technology. Or they're just very, very passively engaged. And so one of the core things that I've chatted with a lot of colleagues about is really getting down to the hardcore thinking through the therapeutic goals. And with all of our clients, pivoting to teletherapy has really, I think, helped us rethink how are we approaching just goals in general, the kinds of things that we might be working on. Exposure therapy is a great example that has taken on a whole new realm of creativity, possibility, impossibility, depending on the specific stimulus and challenge. So there's lots of things that in working with kids, it really makes sense to really reevaluate, revise, review what those treatment goals are. And do they, A, make sense in a teletherapy atmosphere? Are we accomplishing what we set out to accomplish, either through this medium, but also in terms of just what are folks able to do in between sessions? These are probably things we think about for an adult client as well, but they're especially true for our pediatric clients. And of course, none of these conversations is necessarily in the silo without their parents involved.
Parents have such a central role to play,
Mm-hmm.
particularly, you know, I think whether we are seeing clients through telehealth, I think parents are going to have a role preparing the environment. They're going to have a role structuring and orienting around if we're the length of the session, depending on how we're doing it. They may have a role in helping kids stay focused if that is appropriate for the work that's being done. You know, I know a lot of the folks I'm speaking with, there's sort of a double-edged sword, a paradox here in that pediatric clients are among the hardest to serve through telehealth, you know, because of some of the attentional concerns, because they are so inundated with demands for Zoom calls, you know, throughout their day. Simultaneously, they are also some of the clients who are going to have the hardest time observing those return to in-person guidelines. They're going to have a harder time wearing masks. They're going to have a harder time observing social distance. They're going to have a harder time not coughing in our mouths, things that kids like to do. You know, I think it is, I think, a bit of a paradox in that, you know, we're having to figure out what the best alignment of service is for these young clients. And I think it will be often dependent on the family and what the family feels they're able to do, and dependent on the specific kid. Every kid's different, and what they're able to accomplish in that session, and sort of where they're at in their developmental trajectory.
I think that's a really important consideration, where they're at in their developmental trajectory. The younger the child, often the more either engaged or entertaining or involved you have to be as the therapist with the child in session. And or the more you have to kind of have the activities planned of how that is going to help the child move through whatever the therapeutic components are of session. One of the things that I think is really key is the length of time of session is arbitrary. It's not necessarily set because 45 minutes is somehow empirically validated to be the best amount of time possible. It has a lot to do with just how we've crafted and created our time slots and our time with patients. And we know with exposure therapies, sometimes the longer the better. But often with younger kids, we don't have to stick with that 45-minute session. And in fact, it might be something we need to think about, that the young child, we might only need to be expecting them to pay attention for 5 minutes of time, and then they go off and do something else and come back for another 5 minutes of time, for example. Depending on, again, the therapy goals, the nature of the treatment, all of these are factors that we would want to consider as we're either pivoting, or if we've already pivoted, we may have discovered some of these things, and figuring out some handy dandy tools or strategies that you wouldn't necessarily use if you're both in the office setting, but perhaps in the virtual setting become important to help the young client really pay attention. So, I Spy and color games in my background may actually now be something that makes sense to help them learn with the focus and help them kind of manage this shift.
You had mentioned, Margot, I think in our prior conversation, the use of behavioral sort of either token economies or some sort of behavioral motivators to, help kids stay on track. I know a colleague I know here sends out to her young clients a therapy care package, which we could think about the COVIDiness of spreading whatever, but I know she very thoroughly bleaches everything, and there's instructions written, sit for 1 week before the child opens it. But, she sends a package, and in that package, there are stickers, there are fidget spinners, there are sort of toys that kids can manipulate. And there are things that she will use that they can do together, tasks they can do together, sticker books they create together, manipulatives they work with together in the context of the work they are doing, either explicitly, that is the goal itself in the case of helping refine some fine motor things, or alternatively, it's just a distraction, as they're talking about what's going on in the child's life. I sort of asked her to give me all the iterations. So, I thought that was a very clever workaround. An additional expense, to be certain, and additional time, but she felt that it helped her clients attend to the session for longer periods of time and with greater emotional presence. And I thought that was a great hack that I wanted to pass on.
I think that's fantastic. And, a lot of behavior therapists are used to having toys and tokens and stickers and things that you pass out, which obviously don't transfer very well over the video conference. And I think finding ways to help either keep track and show some of those sticker charts in terms of your office and something they can do in theirs is fantastic. I think also true, even kind of middle schoolers and teenagers are really starting to feel the loss of connectivity with the person who's the therapist through the video conferencing. And so I love that idea for a way of reconnecting in not necessarily a personal way, but it is a tangible way that you've sent something out. And of course, always making sure you have permission from parents and talking through with them. But helping guide through these times of being creative is, I think something we really have to think about. It's not just make it the same as what the in-office therapy was. And as we pivot back to the office, we may have learned some things about this time, and we may not be the same moving back either. And so, as you point out, getting back into the office, thinking through these ideas of, what are kids able to manage and how are they doing in their own home worlds of managing mask wearing and not touching and all of those kinds of things will be really important conversations to have.
Absolutely. Absolutely. I'll share also, this last week, I overheard someone basically threaten their child that if they did not meet with me, they would not receive dessert. And I thought, well, maybe not that reinforcement.
Well,
Okay. Well, we had talked, Margot, you and I, about sort of both younger clients and then as well working with elder clients. I know, Margot, you had sent me an article that was very interesting, talking about an increasing gap in healthcare delivery in the context of COVID, in the context of the rise of telemedicine for our elderly clients. And one of the statistics that I was fascinated by, and I think I shared with you, I didn't believe it, I had to go look it up on the Census Bureau, was that between 50, depending on how you slice it, but let's say about half of Americans over the age of 65 do not have broadband internet access. And this was very intersectional with themes of socioeconomic status, is intersectional with indices of rurality, if you live in the city, if you live in the country. So, I don't want to just pin it entirely on an age effect, but I thought it was very interesting, particularly as we are thinking about the strong emphasis on the use of telemedicine for medical care as well as behavioral health care, and especially video conferencing. I think that, as you and I know, and we'll talk about later, insurance companies tend to reimburse at higher rates for video conferencing. Medical centers are, for diverse reasons, inclusive of additional behavioral observation data. You see more, you get more, but they're very motivated to focus on video conferencing. And then in the context of that, we see more and more seniors, not having as steady access to medical care via telemedicine that their younger age sort of cohort might have. I think this is of course true also for behavioral health. And when I think about that in the context of COVID, I think folks who are, there are a lot of implications for how to manage this. I've had some colleagues say, my clients who are older will be among the first I bring back when my practice reopens, because, they are not necessarily having internet access. They may not have a computer that's sort of fit to hold the software. They may be more at risk for isolation. They may be more at risk for factors that, we know COVID is diminishing people's behavioral health. On the other hand, I've had colleagues say, oh my goodness, my elderly clients are the last clients I will bring back because they are at higher risk for transmission of coronavirus. I don't want them coming and going from the office. What if they get it from someone in the office, from me, and I can see how it cuts both ways. And that particularly if we're thinking about someone transitioning back to in-person care, we have to think about how someone's getting there. Folks may rely on transportation mechanisms, such as here in Washington, we have a shuttle service that helps folks who may no longer drive themselves, but need to go to medical care appointments. It is through our county and throughout the state that you would be able to receive a ride, but those are publicly shared vehicles. And how safe is that in the context of COVID? There may be specific requirements, the living environment where they live. I know people in my family reside in places where you can only go to so many appointments, in a given week, unless it is emergent, and that appointment lasts for so long. And, your socialization and things like that are very limited because they're really trying to stem the spread of coronavirus in the context of the living environment. So in that context, we can imagine how telemedicine has this very important role of diminishing isolation, increasing access. But, it feels tone deaf not to acknowledge that if you don't have internet access, if you don't have the hardware, if you don't have the necessary components, you are not necessarily, you're just not going to get the access. And here's where I think telephone has a lot to offer us, because, you know, the statistics, like most folks in the US do have a telephone. I think it's like high 90s percent as in terms of who has telephone access. So here is where I really feel there's this option for us to think about how telephone can, you know, increase access, particularly for those elderly clients who may have diminished access when we're too narrowly focused on telemedicine in a video conferencing context.
I think that technology literacy was the term the article used, and it really, I think, it it gives pause to a lot of consideration in terms of even how we're running our offices pre-COVID to some degree, where a lot of folks are scheduling appointments online, and you know that's the only way. And these are folks that don't know how to access that, even if they
Right.
do have Wi-Fi. It's very complicated. It's not a common experience that they have in their life, and so you know, with COVID, I think it's really accelerated the challenges. And certainly there's some programs cropping up to help folks with access, but these are all things that I think are really key and actually segue well into some of the things you're going to talk about next, as
Yes.
you may want to bring these items up in discussions with insurance companies as you're trying
Yes.
to articulate to them the importance of what type of care might be needed for a patient.
Yes, I think we've seen that Medicare has expanded telehealth benefits in the context of COVID, which is a good thing. And I encourage everybody to go to the CMS website, cms.gov, if you want to read about the expanded services that they are offering. You know, I think that it is, as you have mentioned, Margot, in previous tele chats, there is this moving environment in which we have seen executive orders that have required insurance companies to offer benefits to the residents of that jurisdiction for telemedicine. They're required to reimburse. In Washington, you know, I know there was a requirement that not only telemedicine be covered, which had already been passed into law, but it be covered at the same rate. This is a moving target. These executive orders expire, things are in transition and in flux. And I think that coming up with a strategy of how to navigate that is very important for us, particularly as we want to make sure that we are able to deliver reliable, consistent care to our clients. Always we mention to go to the ASPPB website, where there is a very nice synopsis of the different jurisdictional executive orders that can state by state tell you what has been passed in your state. But beyond that, when thinking specifically about the insurance companies, if you are working with another group of practitioners, if you work in a hospital-based system, if you work in a practice group of any sort, you likely have an account representative with an insurance company if you are paneled as a group with that insurance company. I will share that, you know, in my practice, I didn't even know we had one until this year. And sometimes it really does take calling the insurance company and trying to find out, does my group panel have, you know, do we have an account representative that is managing us? And the reason I recommend people do this is because it is not only good in terms of having an actual human being to answer your questions, you know, about telehealth benefits for a client, or to learn about the policies of the company, or particularly how they want things submitted. But additionally, Margot, I think it speaks to this issue of advocating. It's a human being to advocate with. So, you know, for an example would be if a client really, video conferencing doesn't make sense for them, you know, but telephone would, having another human you can call and talk to and explain the situation. I think there is some collective bargaining power if you are in a larger panel and are able to contact an account representative. So if you do happen to practice in a context where you have larger insurance panels, I would encourage you to reach out to that insurance company and discover if you have an account representative. If you already know who that person is, don't lose their number. It seems very valuable in the current context.
Well, and I think also, Sarah, it's very helpful if you have one person to contact over and over, because they get to know you, right? And you can start to build that relationship with them, and
Yeah.
you know, you can have more individualized conversations about, you know, a variety of patients on your caseload versus just in general. And I think there's a benefit on both sides when that happens, where you get a person you get to know and you kind of can have some I guess, maybe trust or rapport in terms of what they're doing for you, but they also get to have that in terms of what you're asking and get to know kind of what you're trying to learn as well. And so I think that consistency of talking to the same person over time can be hugely
Yes. And be nice to them. Be nice to them over time, cultivate that professional relationship, because it's probably one, that you're going to end up utilizing and they you over the years. I think this is no proxy though for, of course, working with our individual clients. I think, from the moment of informed consent, I am trying to message to my clients that I am not the insurance and they are not me. And I try to share with them the possible outcomes that could happen. This may pass and everything goes fine. It may be declined, and we'll have to think about the financial liabilities of that, and that's spelled out in their informed consent document. Or we may not know for a long period of time. Here in Washington State, one of the major insurers had a big transition of their internal systems, which meant that claims were delayed 4, 5, 6 months, very, very long. And so there were all these clients, getting these statements of saying pending, and they're wondering what's going on. It was a long time for the practitioners to go without being paid. So each of these folks are going to have to figure out what their policies will allow, what is covered and what is not covered. And so my own practice is I ask my clients to figure that out. I will acknowledge that's not always how it goes. Sometimes it's the case that they actually don't know the benefit. And when push comes to shove, something is denied that we thought was covered. And in those moments, I do try to help them advocate. Other people have different practices where they are confirming benefits with the insurance themselves before they ever serve the client, not really opining on which way to do it, as much as for us to have awareness around the fact that telemedicine benefits are variable and they are in flux with these executive orders.
And I guess I can't emphasize enough that if you're working with one carrier, individual patients have different plans. So just because you have an answer for one patient doesn't mean it's the same answer for another patient. And
Right.
It really is individual. So it does mean calling or having multiple conversations about that.
Well, Margot, I am looking at the time and I'm seeing we got some great live questions. Shall we pause and answer some questions?
I think so.
Okay, this is a really good one. I like it. How would you respond? Because I feel like I thought I had the answer in the middle of the question and then I didn't. How would you respond to an adult client who attends a telepsychology session while in their car, they said while driving their car, while in their car, and feels that they need to keep on driving to their destination?
Well, I will say this is a very common experience these days. And I've had several people ask some similar questions. And I think some of the things that have happened is our experience with the convenience of video conferencing has come full circle now to we just fit it in whenever we can. And that's of course not the experience we have as the practitioner on the other side. So I think there's a few things to be said. Hopefully they're not driving.
Well, they're driving in this.
Oh, they're driving in this scenario. So
yeah, they're going down the road. Yeah.
That makes it even easier because it's clearly not HIPAA compliant if they're not driving. So we do want to ensure that above all else and figure out those aspects. If they're driving, it's not safe. So
right.
I think at that point, my recommendation would be, because, I might know the laws locally, but I don't know the laws everywhere and where this person is calling or asking a question from. But I think just across the board, from a professional standpoint, it's probably best practice to say, let's reschedule.
I'm with you.
We'll do that on email sometime later after you get to your destination.
Not right now. Yeah. I'm very much with you. I think that I do see clients in their cars, seated, not driving, in circumstances in which their homes just do not accommodate the type of privacy that we require to have a HIPAA compliant confidential session. That being said, I would feel the same way if they were on Bluetooth and driving. I would feel the same way, I want you doing one task and that task is therapy. If there's somewhere you absolutely need to be, then I'm going to let you do that. If you're having something that's emergent and you need to be driving there, then we're going to reschedule. Alternatively, if you're 5 minutes, I've had people try to do this and they're 3 minutes away. They said, oh, well, I just need to park. Say, okay, we're going to hang up the call, and we're going to reconnect in 3 minutes. Because, frankly, let's say they have a car accident, let's say something happens. I don't know what the liabilities are around that transparently, but just from an ethics perspective, I want no part of that. I don't want to feel that I in any way contributed to their inattention, while operating a car. And so I would say I'd be kind of strict on that one and tell them, no, we're going to reschedule, and it may damage rapport, but I have to think somewhere, somehow folks get that this is, a usual expectation of healthcare would be to not be driving while doing it.
Yes. I think also, just kind of a side note that popped up for me, I have noticed recently in walking through parking lots that there are a lot of people having conversations on their speakers that are in their whole car. And when you're on the outside of that, you can't actually hear that conversation quite clearly. Now, you can't hear what the person in the car is saying, but you can definitely hear the car speaker outside the car. So from a HIPAA compliance standpoint, that's also something to keep in mind. That was an excellent question.
That was an excellent question. We have another really good, there's a bunch of good ones. I'm going to do two quick short ones, and then there's a substantive one. We had someone ask, when is the executive order dated to expire for insurance companies to provide coverage for telehealth, telepsychology? It's a great question. And unfortunately, the answer is short, but not so sweet. It varies. So that is determined by the jurisdiction in which you are practicing, and it will vary by jurisdiction. My best recommendation is to go to asppp.net, I believe that's correct, the Association for State and Provincial Psychology Boards, and they will have an overview for each jurisdiction, each state, each province, and the US and Canada, to give you when those were initiated and when those executive orders will expire.
And we have those links on our resource slide.
Yes, that will be imminently here. Then we have a question that says, is FaceTime video conferencing? Yes, it is a form of video conferencing. I will note that it's not one of my preferred ones. I know, Margot, you and I talk about the manner in which we do like products that are designed for healthcare. FaceTime would be what we would call a non-public facing video conferencing product. In the context of COVID, there has been an announcement from the US DHHS and Office of Civil Rights saying we're okay to use our Skypes, our FaceTimes, our Zooms. That's okay. But that, I think Margot and I have sort of gone on record saying we really like the ones that are for healthcare. We like Zoom for telehealth rather than Zoom Pro. We like Doxy.me if you're looking for a free option. We like the video products that are integrated into your electronic medical record, such as Simple Practice. So, and many others. We're not endorsing one over another per se, but, we like something that really is designed with a healthcare provider in mind. I have a substantive one here for you, Margot.
All right.
I would appreciate some discussion and guidance specifically around neuropsychological assessment via telehealth, particularly for children. Testing is typically half of my practice, but I haven't been doing any testing since March due to COVID and the many complications I see with trying to do testing in non-standardized ways. I'm curious if some or many practitioners have been doing testing, and if so, how people are navigating this, what assessments people are using and have had success with, tips and tricks, and how practitioners are navigating parental involvement, as I assume this would often be needed with younger children especially. This is a really big question. I think we'll get to some of it, and I would encourage this person to reach out to us over the email if there's questions that we don't get to.
This is probably assessment in general, not just with children, is probably the one biggest area that has had the largest hiccup with COVID. I have colleagues across the board from not doing it unless it's in person to, well, we're pivoting and trying to figure out how we can administer a lot of these things via telehealth and video conferencing. And there's, I guess, caution that I would say with both of those. The caution with pivoting and trying to administer even verbal tools over video conferencing we have issues about security and validity and reliability when we don't know who else is on the other side. And it raises a lot of questions and concerns about aspects of test administration that are much broader than the work that psychologists do within an assessment setting in terms of clinical practice. These range all the way to the licensure exams, who are also trying to figure out how do we administer these things either remotely or virtually. And so there are very many considerations about the reasons why we would need to do that assessment right now at this moment. And so I think that's the first thing I would ask. If this is a, child that needs an assessment to obtain disability, there might be some different motivations right now for what's going on. And if we're using the parent as a kind of a preceptor for that assessment or somebody helping out, we need to be very cautious about the considerations of their motivations in terms of the outcomes of the assessment and what we can't see from a single video line when we're doing that in video conferencing. Pivoting that all the way over to the let's return and do it in person. And that raises a lot of questions, both about sanitizing and cleaning assessment tools and your closeness and kind of the office atmosphere and ventilation and all of those pieces, to how are you changing up that administration with all those considerations so it's no longer administered in that same standardized protocol. And again, it does come back to why are we doing this? What are the questions we need to answer? What are the motivations for having that done right at this moment? And if they were scheduled in February for assessment before this happened, are even those environmental factors the same, or even those clinical questions the same at this point? So it is a very deep question and a great one. I think we could do a little bit more in email response, but to keep it short.
Yeah. I'll note we also, in prior telechats, if folks wanted to look through the blurbs, we did address this more thoroughly in a previous one. Sorry not to go in deeper now, but I agree with much of what you're saying. My general gestalt is revisit why. Is it going to be something that's held up to forensic standards, something like that? Can we abbreviate the battery? Can we use online assessments that have been normed and are created for, virtual? So we have Wisconsin Card Sort we can do virtually. We have some of these that have actually already made that leap. I also think a year from now, this is a very different conversation, because I think the companies that generate these assessment measures are working hard, to bring these online and to think about how best to do this. We have so many good questions. I am going to move us on to the ones that were previously submitted, just because these folks have to take a post test and we have to be sure to get to the content that's on that.
We're having the time too, Sarah. So I'm thinking there are some really awesome questions that we have, but certainly the one that was up next is about interjurisdictional conundrums. That's what I'm calling it now, conundrums.
Conundrums, I like it.
There are many forms of this question. I am going to read a couple versions of it that came in, and then rather than answering specific questions, I think giving some guides to the steps of when it's your interjurisdictional conundrum, what are the steps that you need to take to really be able to answer that question? So I'll kind of finish with that caveat, but these are the flavors of the questions. Therapy client from the therapist's jurisdiction travels for vacation to a different state and completes a therapy appointment while they're on vacation. What law applies? So that's kind of one version of the question. Another version is a therapist wants to move and remain practicing remotely from their jurisdiction, they're licensed in, for example, Michigan. Is that okay to do? And so, there's a few caveats because there's, they're moving to a different jurisdiction and, how do they maintain that practice? So no matter what the interjurisdictional no matter how you get to the interjurisdictional practice, I'm so pleased people are identifying that, hey, wait a minute, there are these issues coming up, right? I'm in one state, I'm licensed in that state, and now either I'm moving or traveling, or my client's either moving or traveling.
Mm-hmm.
And there is an assumption there that we met in person or we started the relationship within that jurisdiction that I'm licensed and the patient lives. So that's one assumption. There's a very different set of circumstances if you are now recruiting from across the country for people to come into your practice, and I'm not answering that question right now. So if you want to know what laws apply, you have to look at all the laws involved. And so the very first step is to look at the law that you're licensed under in your jurisdiction and figure out what executive orders might be in play right now and when they're going to expire. And also what telepractice laws or requirements are in place in your jurisdiction and what that includes. Is it just within your state? Are you in a jurisdiction that's now in the compact, in which case you may want to think about becoming involved with those requirements? Maybe you're not, but you need to know kind of what do those laws allow you to do with telepractice within your state and then outside of your state. The next thing you have to figure out is the jurisdiction that you're either moving to or that your patient's on vacation in or that you're vacationing in, and you need to evaluate their laws in the exact same way. So you need to contact or look through their licensing board laws in terms of both licensing and telepractice and the executive orders. Once you've done all that, if insurance is involved in covering any of this, you're going to need to make a phone call to the insurance company to find out if they will allow coverage for you if you are no longer in the state or your patient is no longer in the state. So those are kind of the step-by-step things you need to do to think about how to come to an answer. And no matter what your question is, those are going to be the steps that will articulate back.
I know, Margot, you and I have talked about the manner in which we almost think it's easier, and I know the risk managers say something similar, to serve a client internationally to another country where the practice of psychology may or may not be regulated, licensure may not be required, than it is sometimes to deliver interjurisdictionally between states. It can ironically be almost harder to go between provinces, between states, than it is to go internationally.
Exactly. And this isn't the licensing boards trying to make it difficult. This has to do with the Constitution of the United States and states' rights to regulate these things individually. And I know we're working hard to try and get those all online and similar, but there's always going to be some differences.
Well, I think in a nice segue, we're thinking about how the world is changing and how we are meeting it to transition. It is that time of year. It is back to school time. I know a lot of us with kids are thinking about it. I know I am. And you and I, Margot, have been talking about the ethical and sort of clinical recommendations for new trainees, new practica students, new students requiring supervision, perhaps people who've never done any training previously and are coming into the work of being a therapist in the era of COVID. Many of these students may be going to programs that are entirely engaged in remote learning. Alternatively, so I know a lot of schools are working out sort of mixed models wherein there are pods and social distance and masks, and they're trying to figure out ways. But regardless, there will be some portion likely that involves remote learning for many new trainees. And so
I don't want to interrupt, but I just want to say this might be our first cohort that actually interviewed in teleform and may never have met the faculty in person.
That's amazing, right? That I think there are so many iconic experiences. Before we began the webinar today, we were trading stories of internship interviews and the likes. It would be quite a different cohort experience, as you say. I think, I think for those of us who are engaged in training, engaged in supervision, we want to be thoughtful about how to serve these clients, particularly those who are going to be entirely online. I've noticed that the marketplace for technology products that support online learning has exploded, and I believe will continue to do so. We have products like Google Classroom, we have products that are older like Blackboard, Dropbox, really any web-based file server transfer program that allows the facilitation of back and forth can do, but many have specifically oriented themselves around education and trying to help facilitate, giving out lessons, making available PowerPoint slides, collecting assignments, some of these more mundane things. Many universities have already established that. It's not like back in my day when you actually brought the paper into the professor, but they have that framework, but now they are augmenting it with video-based instruction, with lectures that are recorded, and of course, with clinical training practica that are online. So, my general recommendation to people engaged in training is, of course, look to our American Psychological Association, look to the Committee on Accreditation. They're offering excellent guidance. Their websites have good materials, that speak specifically to the needs of people engaged in training and education. Generally, I would say, look at our curriculum. Are there components of the curriculum that more easily transition? And are there components that are going to be retooled? And I really say this with an eye towards how can we be using these moments not to try to just teach the same skill we have always taught. I think it is challenging to suggest that I'm going to teach someone remotely all the idiosyncrasies of doing in-person therapy. I can speak about what it's like to lean in close to a client when they're feeling, a certain way. When that person's not in the room with me, it is going to be more challenging. I know many schools have projected and predicted that they hope to be returning to in-person training, by, of course we don't know for sure, but by sometime in 2021. So my recommendation generally is if we work under assumption set that eventually we'll be going back to in-person, consider using the earlier part of your curriculum to focus on things like helping people use telehealth skills. Telehealth is here to stay now, and these trainees will need to know how to use it, and training them on telehealth virtually it's a lot easier than training them in in-person therapy virtually. Eventually they will need to know both, of course, but there are different opportunities for student observation of clinician, of supervisor skills. There's different opportunities for the supervisor to observe the student, through the use of video conferencing. And I think that as we orient this, perhaps towards the beginning of our semester, there is this opportunity to try to use the modality as best we can to educate. And don't forget the socialization piece. That's the last little plug I'll put in there. So much of grad school is getting to know your colleagues, is getting that peer support. It's very easy to go to a very transactional model when we're doing Zoom appointments. So I encourage folks to, in addition to thinking through what these remote training sessions can look like, make sure you have that wine and cheese hour or that check-in or a study group or something, for folks to form some of those relationships that will prove to be important throughout their careers.
And you do raise some really important points in terms of, it's going to be interesting as we are trying to move back to in-person and how we might choose to then incorporate training for that if as faculty we're not in in the office yet. But I do think there's going to be a shift in terms of some of the competencies. And, as we've had a lot of competencies grow, this is going to be a huge area that we really need to pay very close attention to in terms of both virtual skill sets as well as in-person skill sets. And just like we're missing a lot of behavioral observations from our patients, we are going to be missing an awful lot of behavioral observations from our students. And super, super important for us to really hone in on those, I think, and fine tune. And everybody, is coming in with perhaps a bit more stress and also excitement, but being able to really evaluate those pieces and talk into those and be, engaging in those transparent conversations right from the get-go. I think we really have an opportunity to elevate our training very differently than we have in the past.
I agree. And there's no proxy for asking questions, asking tons of questions, because we cannot make the same assumptions, that we're having the same moment. And we never can, but perhaps even more so, over this modality. So Margaret, we have a lot of great questions. It is 2:52. So I thought maybe we could do one or two and then we'll start talking about CE.
That sounds fantastic to me.
I will mention we did receive some questions that were specifically salient to themes of informed consent and initial intake documentation, and I would refer folks back to earlier telehealth chats. Sorry to punt, but if you go back and look through the descriptions, there are longer explanations on these themes. One I just wanted to tackle quickly, and then we'll get on to talking about some of those wrap-up slides. We had a question, any thoughts or special considerations related to doing group therapy via telehealth? This is one also we've covered in prior chats, and I'd refer folks back where we go on and on about it. But briefly, I would say, yes, absolutely. One, making sure that you get a video conferencing product that is well suited to having multiple people join. I think this is especially salient if you are having people join from multiple locations. So in the case of family therapy, you might be able to get away with having everybody scrunched up around one camera. But if you're doing group therapy where people are in multiple locations, of course, that is a factor. And then additionally, I would say being really thoughtful about issues of informed consent, privacy, and confidentiality. Anytime we're serving people in their homes or in environments outside of our own office, there is an additional risk that someone's going to walk through the background, someone's going to overhear that call. Now, when we think about it in a group therapy context, that risk just increased exponentially because we have many players, and if one person is lax on their thoughtfulness about themes of privacy, confidentiality, and information security, it impacts the entire group. And so from my perspective, this is something that I speak a great deal with before I ever start the group. I speak with clients a great deal with even before. That's part of the informed consent process, and that's part of the contracting process about participation in the group, inclusive of consequences that if they're not able to maintain the confidentiality and privacy of other people in the group, it will be something that would result in them not being able to participate in the group. So here we are at our resource slide. Some of these we've talked about already, some of these resources and guidelines, inclusive of documentation from the Trust and the American Psychological Association, that telepsychology guidelines. The American Telemedicine Association, of course, offers best practice documents. We have mentioned several times, throughout our talk, the Association of State and Provincial Psychology Boards, ASPPB, a link to their website, Capterra, a company that offers software reviews if you're thinking about getting a technology product designed for healthcare, and then the Council of State Governments, where you can see some of those state executive orders in greater detail. And then, of course, your state board guidelines, no proxy for that, looking at your licensing board that gives you your license and checking out what information they have to give you specific to telehealth in the COVID era.
Sarah, I'm just going to also shout out again the Council of State Governments, and there is a link to that on the ASPPB.net website, but they've started organizing so you can search by, was in effect previously, now it's expired, now, soon to be expiring. So there's a number of filters that you can use, and super handy. Because those come out of the executive offices of each jurisdiction as well. And so for me personally, I've looked around on a few different jurisdictions in the psychology websites for the licensing boards, and sometimes they're really hard to find, where to go. They're not all connected up with their governor's office. And so that is sometimes really helpful to look there. I think one last thing too I wanted to mention, Sarah, and that was just reaching out and asking these questions is so key and important. And, asking your colleagues what they're doing, and, or, having those consultations with your colleagues, kind of figuring out there is variety. Everybody's doing things a little bit differently. But then, seeking that information from the original source from a licensing body is so terribly helpful.
Mhm.